Okay, good morning, everyone. My talk is related to Indigenous heart failure, and it's titled A Call to Action. It's part of the Ted Rogers Center Annual Symposium on Heart Failure 2021. My name is Jeff Redding. I'm chair of the First Nations Health Authority Heart Health. I'm a professor and director at Simon Fraser University in the Faculty of Health Sciences and direct the Center for Indigenous Governance there. And I also direct Indigenous Health Education Access Research and Training with the acronym IHEART, based at St. Paul's Hospital Cardiology, that's supported by the Bank of Montreal, the Heart and Stroke Foundation, Providence Health, the Health Authority, and Simon Fraser University. I'm really pleased to be giving this presentation today. So to begin the context here, I would like to just let you know a little bit about the political economy of Canada and the world in terms of colonization. This is from the 1700s, and it basically shows how European powers treated the world that they considered to be uncivilized at that time to be possessed by European nation states. So you can see at the bottom, the colors refer to what they call possessions, literally British, French, Portuguese, Spanish, and Dutch there in different colors. So you can see in the 1700s, that idea that imperialistic colonization and spread around the world and included many parts of the world, but also what's missing is most of the world at that point in time wasn't colonized. And so that's kind of the context. Indigenous peoples lived in the world and in North America and in Canada. And, through the process of colonization, were marginalized. And that marginalization had health impacts that look at all indicators, including heart failure. With respect to more recent challenges, pandemics have affected Indigenous people since the time of European contact because there were very few innate immunities to those pandemics. And we did an article in the Washington Post at the beginning of the COVID pandemic. And it looks at this notion of how pandemics exacerbate deep-seated health and socioeconomic inequalities throughout the world. So it's well known that these inequalities exist, and that in the context of these social and economic health determinants and inequalities, something like a pandemic can spread like wildfire. And here is Anna Banerjee from the University of Toronto Medical School, stating that it's particularly dangerous for tribal elders that occupy a special place in their communities as knowledge holders. So if we're looking in the disparities of heart failure for Indigenous peoples, we really do want to kind of promote a call to action. It's well known that there are higher rates of cardiac risk factors for Indigenous peoples, rates of smoking, high blood pressure untreated, different other factors associated with diet and things that can be changed and adapted and intervened. There's also disparities in the health determinants, profound inequalities and equities that persist in social, economic, health services, racism, etc. When it comes to hospitalization, data shows that Indigenous patients with heart failure are admitted on average 10 years younger. They have higher short and long-term mortality rates and are less likely to visit a general internist or cardiologist in the year following the incident of heart failure hospitalization. So, in fact, the true weight of heart failure among Indigenous people in Canada is unknown. And that's a major gap in terms of understanding the magnitude and scope of the challenge ahead. Again, turning to some of the early ideas here and epidemiology with respect to COVID, it's well understood that hospitalizations and deaths were much higher for COVID patients with reported underlying conditions, including cardiovascular disease, diabetes, and chronic lung disease. And these were differentially higher among Indigenous populations, not only in Canada, but the United States and other parts of the world. And of course, the risk of obesity associated with COVID-19 also looks at these significant comorbidities around smoking, and with the risk going up, the risk ratios going up as the comorbidities persisted. I wanted to just briefly talk about ethical conduct of research involving humans, which is the Tri-Council Policy Statement, Chapter 9. And essentially, this is kind of looking at a notion here of two-eyed seeing, which was referred to by Elder Albert Marshall, Mi'kmaq elder from Atlantic Canada, Nova Scotia. And he coined this term of two-eyed seeing that would look at sort of Indigenous perspectives or Aboriginal communities, as I've labeled here, and Canadian society. And the idea that there could be taking the best of both worlds, if you will, to have a complementary system of knowledge creation around, now I said IAPH is now the Institute of Indigenous Peoples Health at the CIHR. But in any event, this is sort of a notion, a pluralistic notion of looking at research that values Western scientific excellence, but also is relevant to community needs. So the research, why is this necessary? Because the enterprise of advanced knowledge creation or research, it continues to value Eurocentric knowledge systems. It values researcher productivity over research benefit. It values research agendas directed by non-Indigenous peoples, be they in researchers themselves, organizations, or governments. It values projects over relationships. When looking at the cost benefit, little or no time or resources for community engagement, governance, staffing, or research implementation. And really, that is the action part of what I'm talking about. Doing the research is one thing, but actually turning it into action requires that community engagement, Indigenous governance, and having people working in communities to implement the results of that knowledge in terms of new program strategies and actions. And the research enterprise still continues to devalue Indigenous community-led research and trainees, although there has been very significant progress made through the CIHR Institute of Indigenous Peoples Health and other research funding bodies. So some of our research grants are an example here. We are preparing a grant in partnership. I'm part of the team led by Dr. Heather Ross, which is in progress and be submitted. She's based at U of T. We've done extensive work with the New Chalmouth Tribal Council, which is 14 coastal communities on Vancouver Island, where the health director is Lynette Lucas, who's an adjunct professor at Simon Fraser University, Faculty of Health Sciences. We are leading a vaccine safety and efficacy research evaluation with the Public Health Agency of Canada. We just received the stage 1 of a team grant looking at diabetes prevention. We're part of a CIHR network environment for the training of Indigenous health colleague trainees and students, grad students, led by Dr. Charlotte Lope at the University of Victoria. We have an emergency care project that was funded by CIHR under the leadership of Dr. Jim Christensen, who's an emergency medicine physician at UBC, leading that department. We have an early life trajectories, developmental origins of health and disease, which is a maternal child cohort where we track women of reproductive age as they get pregnant, and then when they give birth, we will monitor the health and well-being of their infants as they grow and develop, and do interventions that will optimize that. We, under the leadership of Dr. Laura Arbour, in partnership with Dr. Nadine Caron and Wyeth Wasserman and others, we have a silent genomes project, which is articulating rare but treatable genetic diseases among Indigenous peoples of Canada. We also have a CIHR-funded project with the First Nations Health Authority, which is addressing health and wellness priorities and enhancing Indigenous research and data analytics and looking at different kinds of indicators. We have a First Nations Health Authority tobacco policy research initiative funded by CHR. And we also have another project led by Dr. Laura Arbour, again, looking at genomic variants on heart disease in a northern BC First Nation. And that's really just a sampling of the kinds of research that we're doing that get at heart health and well-being. But I wanted to emphasize that some of it is led by Indigenous scholars and some of it is led by allies who are working with Indigenous teams, but they all represent strong partnerships with communities. So consistent with the ethical guidelines, the Tri-Council policy statement, it balances community relevance with outstanding scientific merit. For example, in our early life trajectories project, we began our process around community conversations around what would be important in the construct of new knowledge. That was prior to submitting the application. We got the planning grant application successful, and then we began to hire the team. We developed ethics and got that approved. And we're moving into the field. So we had a period of time where we could develop a strategy on going forward with the details of the cohort to ensure. Now, this involves collecting biological samples as well as qualitative research, surveys about health and well-being, and access to administrative data over time. So I'm getting closer to the end here, and I just wanted to talk about this notion of a syndemic approach to Indigenous health. And syndemics, if you haven't heard the term, it describes complex epidemics involving two types of adverse interactions: clustering or interactions between two or more diseases or health conditions, so the biological to biological interface, combined with the social environmental factors, the biological to the social interface. So adverse biological interactions between these diseases combined with social, political, environmental factors that cause or exacerbate disease, the biosocial or biosocial interface. So it's important to just recognize that Indigenous health is not, it's in a context of both bio, like viruses or other factors in the environment that can cause illness, with biosocial interactions that intersect. And actually, there's a synergistic effect between that social environment and the biological environments that occur there, which lead to profound, overrepresentation in problems like heart failure and other health conditions affecting, metabolic syndrome, other kinds of chronic illnesses. And so this is the last slide, and it's just looking at, for example, the COVID pandemic, the search for new therapies and science. And it's sort of like looking at a model where the question is, who governs biologic and genetic epidemiology? It has relevance to heart failure and other health conditions. So what goes into it are partnerships, the science, the regulations, the clinical research and trial network, and personalized medicine. And then this is called what I call frictionless research. It creates an environment, and I would suggest that that's what's needed in the area of Indigenous health writ large, but also the idea that it requires investment of resources, people, and funding to be able to create real-time analytics, to be able to look at opportunities to use advanced knowledge to transform the health of populations. And I think heart failure is an excellent place to start. So with that, I want to thank you for the opportunity today and for listening to me. And I would like the opportunity to, unfortunately, we can't meet face to face and go for a coffee or something, but maybe in the future that'll be possible. So thank you for your attention. My pleasure to be here. Take care.